Good morning, everyone. We'd like to get started on time. Would you please find a seat? Wow. I've never had so much power. Are we all here? Great. So thank you all for being here. My name is Linda Cobert. I am Research and Communications Director for the Myositis Association. And it's my great pleasure to be on stage with these amazing individuals who are so committed to research and treating myositis diseases and helping us move the needle on finding a cure. So today's session is about, we will introduce these folks, they will introduce themselves, and then we will invite you all to ask your questions of them. And so, so let's get started, and we'll start on this end, and I'll ask our panelists to introduce themselves and say just a little, where you're from and a little bit about the kinds of research that you're working on.
So we're missing.
And I've been told to please speak directly into the mic so that everybody can hear well.
Okay, and turn it on first. We're missing Dr. Lloyd. My name's Steve Atterberg. I am a rheumatologist, and I am arguably the happiest person up here because I retired in February. Hey, thanks. Formerly, I was at the Mayo Clinic for 20 years, and I've been a member of the Myositis Advisory Committee for a number of years, and I'm privileged to be the current liaison to the board of directors. My activity at Mayo over the last 20 years has primarily been as a physician and care provider, but also involved in clinical research. And that's all I'll say, because I'm not doing it anymore.
So I'm Helena Alexandersson. I'm a physical therapist and a researcher at the Karolinska University Hospital in Stockholm, Sweden. And I'm happy to be here. This is my 6th year on the board. So my research focus mostly on what happens in the muscles when you exercise and what kind of exercise is feasible and safe in different stages of primarily adult myositis. But I also I'm interested in how can we measure the effect of different treatments, both when in terms of muscle function, but also looking at patient-reported outcomes. And also, I'm very interested in patients' experience of different symptoms in myositis, for example, pain. I want to understand more what kind of pain it is and to understand how the pain can be treated. Thank you.
Hello, my name is Olivier Benveniste. I'm running the Myositis Center of Paris, France. My training is in internal medicine and clinical immunology, but I also spent some time with a neurologist in Oxford, UK. And we are doing translational research. That means that In the team of research, we look at the effect of, for instance, the autoantibodies on the muscles, and then we move to clinical trials in collaboration with Andy Mamen, for instance, regarding the anti-SRP or anti-HMGCL necrotizing myopathies, and also we are running trials for inclusion body myositis.
Hi, I'm Sonia De Santis. I'm actually a lung doctor from Johns Hopkins. I take care of patients who have interstitial lung disease as a part of their autoimmune myopathy, typically polymyositis, dermatomyositis. And my area of interest is really to understand what puts people at risk of the lung being involved in these diseases, how to identify the disease early, and how to find the most effective treatments for these diseases.
My name is Tai Chung from Johns Hopkins. I'm a doctor of physical medicine and rehabilitation. This is my first year on the board. I'm interested in exercise intervention and rehabilitation intervention for myositis. When I say rehabilitative intervention, that includes physical, occupational, and speech therapy intervention. So I work with a team of PT, OT, and speech therapists in my clinic.
Good morning. My name is Ann Reid. I am a pediatric immunologist and rheumatologist at Duke University. I started my career really studying the genetics of muscle disease, both in adults and children, added on looking at immune cells that are in the muscle and trying to figure out what they are and what they're doing. And more recently really have looked at trying to develop ways to detect if the disease is still active. I've also done work in clinical trials and co-led the large rituximab and myositis trial that was run with Chet Otis at Pittsburgh many years ago, so I've dabbled in multiple things.
My name is Kanneboyina Naga Raju. I go by Raju. It's a very long South Indian name. So I'm at the State University of New York in Binghamton. I'm an immunologist by training. I study the basic mechanisms, how muscle cell damage occurs, what are the interactions between immune cells and muscle cells. And I've been working in myositis a little more than 2 decades. Dr. Paul Plodge introduced me to this to study myositis, and this became the major part of my career. And some of you know that I've been working for the last 10 years also to find a prednisone replacement. And so far, I think everything is looking good. Hopefully, in another year or so, we have, at least we will go to FDA to see if they will approve the drug. So we are still continuing to do the trials. So let's cross our fingers. We'll talk next year.
My name is Chris Weil. I'm at Washington University in St. Louis. I'm a neuromuscular physician, so I see patients in our neuromuscular clinic, and I also have a basic and clinical science research lab where we're interested in studying mechanisms of protein degradation and protein accumulation in muscle and how that leads to muscle dysfunction in diseases like inclusion body myositis. We're interested in taking those findings and translating those to clinical care. We've become more interested recently in trying to, as we start to understand these mechanisms in cells, translating them to mice, and then eventually bringing them into humans, we've recognized that there's a clear gap in just understanding how patients progress, how patients, what measurements we can use to understand patient changes over time. And so we're much more interested now in also looking at novel outcome measures in inclusion body myositis as well as in other myositises.
My name is Rohit Agarwal. I'm a rheumatologist from University of Pittsburgh. I've been heavily involved with clinical trials in polymyositis and dermatomyositis and trying to develop new tools which are called outcome measures on how to to measure the outcomes in our patients when they are evaluated in clinic or in clinical trials. What I've done lately is I'm trying to come direct to patient research area where I'm trying to do more and more research by directly approaching the patient for research data and research analysis. And I have a study ongoing called MyPacer study, which is myositis patient-centered tele-research. And I know some of you have participated in that study so far, and I'm really thankful to you and TMA for support of that direct-to-patient study of mine. Thank you.
My name is Andy Mammon. I'm a neurologist and neuromuscular specialist. My research group is at the National Institutes of Health in Bethesda, and I see some patients there. I also am still part of the Johns Hopkins Myositis Center in Baltimore and see patients there as well. And our lab group has for a while been particularly interested in myositis autoantibodies and the idea that there are probably 10 or so different major myositis autoantibodies, and that perhaps each of these actually define distinct diseases. We know patients have different clinical features with the different antibodies, and now we're really interested in focusing in on what are the underlying mechanisms that may drive disease in those different groups, with the idea that patients with different autoantibodies, different diseases might benefit from different treatments. So that's kind of one of the main things we're working on these days.
My name is Marianne de Visser. I'm an adult neurologist, and I'm based at the Amsterdam University Medical Center in the Netherlands. In Amsterdam we have a myositis expert center, and my research focuses on how to improve diagnostic tools, and in particular muscular imaging, MRI, and muscle biopsy, because we know it can be very challenging to properly read a muscle biopsy, and we are also involved in how to try to get more effective treatments. We participated in clinical trials, and we also initiated clinical trials.
Good morning. My name is Florian Ernst. I'm a rheumatologist. I work at Mayo Clinic in Rochester. I'm primarily a clinician, and I treat patients with dermatomyositis, polymyositis, and inclusion body myositis. I have been involved in clinical research these last few years, primarily treatment trials with dermatomyositis and polymyositis. This is my third year on the advisory board, and I'm very happy to be here and part of this organization.
Thank you. My name is Mazen Damashki. I'm a professor of neurology at the University of Kansas Medical Center, and I'm very delighted to be here with you. One of my privileges at the University of Kansas is that I lead, by all measures, the largest clinical trials unit in neuromuscular disease in North America. And we're involved in trying to advance disease knowledge and also treatments for the myositis. Thank you.
Good morning. My name is Tessa Mafar. I'm a neurologist by training, a neuromuscular specialist, and I'm currently the chair of neurology at University of California, Irvine. I've been involved in myositis research since 1995 when I started my fellowship, mainly looking at, like Dr. Mammon, myositis antibodies and differences in the clinical picture. But lately we've been spending a lot of time on inclusion body myositis with the intent of doing a longer natural history study just to see how disease behaves over a longer period of time, defining new outcome measures and some biomarkers in the blood for it.
Good morning. My name is Malin Regat. I'm an occupational therapist and research from Karolinska University Hospital in Stockholm, Sweden. So my research interest is in hand function and how it affects the daily activities. I have also done a study on workability, which I think is very interesting and important. I'm also involved in a international collaboration about outcome measures that are important to the patients, patient-reported outcome measures. So that is also my interest. Thank you.
Good morning. My name is Wael Georgiou. I'm an immunologist and a rheumatologist. I practice at The Ohio State University where I see patients with different kinds of myositis. My research involves also a quest to find drugs other than prednisone and immunosuppressives to treat myositis. We specifically look at cell membrane that we have evidence to show that it's compromised in some forms of myositis. And we are looking for ways to try to repair that. So hopefully in years to come, we'll be able to come up with some strategies to help with that. Thank you.
Hi, my name is Ruth Vlegels, and I have the pleasure of being the dermatologist in this group. And I'm very fortunate because I get to see both adults and children with myositis because I work at Brigham and Women's Hospital and Boston Children's Hospital. And first and foremost, I think it's been a complete honor to take care of patients with myositis. I find all my myositis patients to be extremely dedicated and resilient, and I just really think it's an honor to take care of patients with myositis. I've really been involved with dermatomyositis since I started my training, and about 7 years ago, we literally on individual patients started collecting blood and biopsy samples, and now from those data today, we have a randomized controlled trial specifically for skin disease at 12 sites in the United States, so that's been really exciting. And then last, I think one of my most important jobs related to myositis is educating others. I lecture very frequently on these diseases, and I lead one of the 6 courses at Harvard Medical School, and I make sure we have a full session dedicated to myositis every year because I bring in patients, and I want every Harvard medical student to graduate knowing what myositis is, ideally how to recognize it, and also really to try to get young doctors interested in being myositis experts down the road. So I really am excited to be a part of this group. Thank you.
Hello, my name is Jens Schmidt. I'm a neurologist from Germany. I'm based in Göttingen, and I'm head of the Neuromuscular Center. I think our center is unique in that we really work together in a very interdisciplinary fashion. Rheumatologists, neuropathologists, pulmonologists, neurologists, pediatric neurologists, geneticists working together and seeing patients, caring for them on a day-to-day basis. Our aims in our research group are the mechanisms of myositis. We participate in international clinical trials, and we develop new diagnostic tools for myositis and other neuromuscular diseases. It's my pleasure and honor to be on the board, and I'm excited to be able to meet all of you. Thank you.
Good morning, my name is Perry Shay. I'm a neurologist at the University of California, Los Angeles, a neuromuscular specialist, primarily a clinician, and I see a lot of muscle patients. I participate in clinical trials for muscle diseases. I'm particularly interested in clinical research as it relates to outcome measures that make us, that allow us to be able to measure the efficacy of drugs in clinical trials, biomarkers, as well as clinical outcome measures.
So let's go back around the circle and
Hi, good morning, everyone. My name is actually Tom Lloyd. I'm a neurologist and neuromuscular specialist at Johns Hopkins, and also serve as actually co-director of the Johns Hopkins Myositis Center. I specialize in the care of inclusion body myositis, and also run a lab which is focused on a better understanding of the causes of neurodegenerative and myodegenerative diseases. And in particular, we're excited about our current research ongoing in developing a novel mouse model of inclusion body myositis. And this work is was funded in part through the TMA. So I'm actually honored to be here and part of the board.
Thank you to all of you. And so this is the time when you all will have the opportunity to ask your own questions. I know there might be a few out there. So we have some people who have microphones in the audience, and I will go try and swing back and forth across the room to have your questions answered. My request is that you keep things more general, not specific to your very own case. There will be opportunities later in the day after this session where you will be able to ask those specific questions in a smaller setting with an individual doctor. These folks are also here after the session, and you can always approach them and ask your specific questions then. I'd also like to ask you, for the sake of the rest of the questions that we might have, to please limit your question to 1 or 2 sentences, not a whole, your whole myositis journey, although that is an incredibly important piece of who you are, and we want to acknowledge that, but we need to keep the questions to a couple sentences. And actually, I'm going to ask the first question because I know many people in this room want to hear the answer to this. Dr. DeMarchi, would you mind giving us an update on the arimoclomol trial?
Yeah, sure. So thanks for the question. We look forward for more questions from the audience. The arimoclomol trial, as you know, involves 12 sites, 11 around the US, 1 in the UK. Currently, I'm happy to report to you that as of April of this year, we are fully enrolled all the subjects for the study. The study is ongoing. We're hoping that the last subject will finish in the first quarter of 2021, and after that, later on in 2021, we'll be able to share the results of the trial. Thank you.
Thank you. Okay, let's start on this side.
Thank you. My name is John McLean, and I want to thank all of you researchers for the work you're doing on finding cures and drugs that will help us with myositis. But as an IBM patient, I know that I'm most likely not going to die from IBM. And this goes probably more to Dr. Chung, but to all of you. What really worries me is the morbidity rate from the dysphagia problems with aspiration and then dying from aspiration pneumonia. And are there any trials, or are you going to try to create some trials to lessen the swallowing problems so that those of us with IBM can live longer without coming to the fear of having aspiration pneumonia?
So unfortunately, I don't think there's any clinical trial going on for dysphagia in IBM at this point. We have some preliminary studies that we submitted for publication recently, looking at the video swallowing pattern of dysphagia in IBM patients. It looks like it's more associated with some muscle weakness. When we reviewed previous studies on dysphagia in IBM, there are really not many there. So I think this is an area where we really need more research on. I've been working with our speech therapists and trying to get some team together for more research. But unfortunately, there is any clinical trial just for dysphagia at this point, as far as I can tell. Maybe some other members know about this clinical trial.
Dr. Schmidt?
Maybe I can add to that. I'm not aware of any ongoing clinical trial in IBM. However, there have been several reports of the use of different treatment modalities for swallowing difficulties in IBM, and they relate to a myotomy, which is a one-time and irreversible treatment, They relate to botulinum toxin, and they relate to balloon dilation. I agree with you that swallowing abnormalities in IBM is really a major risk for aspiration, and I would call onto all myositis clinics that all physicians actively ask patients for swallowing abnormalities, because a patient may not actually be aware that he or she has a beginning swallowing abnormality, and there are several scores out there that should be used in order to prevent severe aspiration further down the disease scores.
Thank you.
I want to thank the scientists and physicians that you are for what you do. My question is a blanket question. As a show of hands, can you tell me in your relation with your patients, have you ever seen a patient beat this thing? I am an IBM patient.
That looks like a no. I'm sorry.
Depends what you mean by beat it.
Not for inclusion body myositis.
Over here.
Hi, I'm a patient of Dr. Mozafar. Right now, he's up there shaking his head going, oh God, what's she going to say now? I drive 2 hours to see Dr. Mozafar. Last spring, I was having what I thought might be a heart attack. I had heart issues. I went to my local ER. They had never seen the likes of me. My primary care physician, I had given the TMA booklet to. I don't think she read it in the 10 years that she has had it. Certainly the ER doctors went out into the hallway to Google myositis. What I need to know is, I do have IBM. I might also have a heart attack. Someday I may have cancer. I would like to know about continuity of care for those of us who are fortunate enough to have found a wonderful myositis doctor. But my own medical team, I have asked them to read the physician's handbook. Do you think if I offered them a cookie, they would read it? I would like to know about continuity of care with my overall medical team. Thank you.
You know, this is a very tough question. I'm Marc DeMarchi, by the way. I know you spoke with me about this with Dr. Mozafar earlier yesterday. I think the Myositis Association really is trying hard to try to come up with different ways to educate local community hospitals about myositis. As a matter of fact, in our early meeting today, Mary McGowan was describing the partnership program that Myositis Association was having to engage hospitals in knowing more about myositis, championing myositis. But as you know, as a rare disease being less than 200,000 in the US, in this case, 70 to 100,000 people in the US, not a lot of physicians have heard of myositis, and mostly they hear about diabetes, high blood pressure, heart attacks, cancer, because that's what people experience commonly. However, there's a strong need to educate, and I'm afraid that this is a big challenge that we're not yet up to that goal of having everybody know about myositis. Anybody else would like to add?
Yeah,
Dr. Shay?
Yeah, Perry Shay from Los Angeles. So at major medical centers, it's even challenging to get people, other physicians, to be able to know about rare diseases that are not directly within their specialty. And I think one of the benefits of being at a major medical center, of course, is the fact that they feel comfortable picking up the phone, emailing, calling, their colleague who is taking care of patients with that. Sometimes is a physician who has taken care of a patient like you with IBM, and they'll reach out to us. The challenges of smaller hospitals in the community is something that I don't think that we we've figured out how to do that. We certainly want to be able to reach out and improve the awareness of these conditions and create a network that's a little bit more accessible for these physicians. But I don't think we have an answer to that.
Although I'd say that at least they went out and got on Google to look it up. It's amazing, our residents go and look at YouTube videos before they do procedures. And they've been taught, but just to reinforce, to say, what do I remember? There's so much information that...
I think I would just reiterate what Dr. Shay said, which is I think what you, at least for the moment, what you have to do is encourage communication between the different teams of doctors, because the different teams are just going to have expertise in different areas, and Google's only going to get them so far.
And just to reinforce that, this is since I guided, she lives in San Diego, which is not a small town by any stretch of imagination. But even in San Diego, we have challenges with that. But I think the most important thing is if you have a local physician who's willing to reach out to experts and communicate, I think that's important. So that's one of the reasons I recommended a particular group to her who has had interactions with other groups in the country as well. So I think hopefully that will take care of the problems, right?
I just want to add a comment to it, because I actually think you have a lot of control in some of this yourself too, in that the way healthcare is moved and is moving, and some places in the country it's more like this than others, is in sort of medical homes. So it means that you have a circle of physicians and care providers. Sometimes they're physical therapists, sometimes they're nutritionists who have to care for you. And so it behooves your primary care physician to know you and know what's going on, because they're going to be responsible for what goes on with you over time. And I think that's the power that you have, to really emphasize to them, I want to educate you. What else do you need? Do you want more information from the Myositis Association? What else do you want so you can help me take care of myself as well? And so I think it's a power that I would really strongly recommend that you try and push a little bit.
And we hope that you won't give up on trying to educate your doctors about your disease and what we know about it. I love the cookie idea. If anybody else has ideas for us, we would love to hear them.
My question is regarding more IBM. What are your thoughts on boosting mitochondrial health? Like taking glutathione, niacin, magnesium, NAD, anything to help repair the damaged mitochondria?
I can comment on that. So there's, whenever patients ask me those questions, those are sometimes hard questions because I'm a scientist, and so I want to know: is there evidence? Has there been a clinical trial that shows that works? And so what I can say is that there's no current evidence to suggest that that's going to be beneficial. Now, if you were asked me, if I was a patient or something, is that a bad idea? Absolutely not. Those are reasonable things to try. There's great evidence that mitochondria are impaired in inclusion body myositis. There's a good reason to think that if we improved mitochondrial health, that would be something that would work. That's something we call a therapeutic target. So boosting mitochondrial health is something that would be a reasonable therapeutic target. What I can't say is whether, what that cocktail looks like. I just don't know what that is. And so my comments to patients is if it's working, then absolutely give it a try. If someone's promising you that it's going to work, that's a different story. So if you've gone to a local physician or chiropractor who says, this is the magic, cocktail, I would be suspicious of that. I wouldn't say not take it. I just wouldn't. I would just be cautious about what your expectations are. Yeah. So there's no evidence one way or the other. I don't think you're going to cause any damage.
But I think I agree with Chris. I think taking some supplements which are harmless is probably not a bad idea. I think you have to draw a line on, the first rule is do no harm. So we've seen this in IBM, we've seen this in ALS, where people have flown to other cities. There was a practitioner in Florida who used to give IV glutathione, which probably didn't do any good to anyone and probably caused more problems than that. So I think you have to draw the line somewhere, and if it's costing you an arm and a leg, that's probably not a good idea. If somebody is promising you a cure or a treatment, that's probably false advertisement on that. So I think there are individual decisions there.
Yeah, and then to add to the controversy a little bit, it's that the evidence in the literature about mitochondrial dysfunction in people with IBM is kind of wishy-washy. It talks about levels of enzymes in general compared to groups, but then when you look at an individual patient level, there's not established at any given age how many fibers in the muscle biopsy shows mitochondrial dysfunction. So many authorities have jumped to the conclusion there's way too many mitochondrial dysfunction in IBM when it's really not well firmed up as a fact.
I just wanted to add that just because we see some abnormalities, that doesn't mean it's the cause of the disease. And so, so just
Thank you. Over here.
Hi, my name's David Javins from Seattle, Washington. I'm new to this, and I have maybe a rookie question, but I see PT on both the West Coast and the East Coast. And both PT departments have told me to use light weights when exercising. And at this conference, I've been given the impression that I should be taxing my muscles when I exercise to the point of fatigue. Not fatigue where I'm, wiped out for several days, but fatigue. So I would like some clarification on that.
Dr. Alexanderson?
In terms of improving your strength, you need to work with your muscle to the extent that the muscle is tired. So using light weights, I introduced this Borg scale to many of you. So when introducing an exercise program to a patient, I will just test. So do 15 repetitions with this weight. And then I ask, so how exerting was it? And so if the patient said, well, it was a 1, which is like almost no exertion, very easy. So working out on that, on a weight that gives you that kind of low exertion, it won't do any good. It won't increase your endurance or strength. It's a good way to start exercising. If you have never exercised before and maybe you're afraid of having more pain or fatigue, start on that level, but then increase as time goes by. So the goal intensity would say that you work with a number of repetitions or loads that gives you a heavy exertion, 5 or 6, or very heavy exertion when you are an experienced exercises, when you know that this is working, you've been training regularly for some time. So does that clarify? And it depends on what you want to achieve. What is the goal of the exercise? Do you want to improve your maximal strength? For example, getting up from a chair. That could be a maximal effort for someone with IBM, perhaps. So then I would recommend to train fewer repetitions, but with a higher weight. If you want to improve your endurance, you want to go for longer walks, you want to be able to go uphill, climb several stairs, go skiing, any activity that you need to do for a longer time, then I would say train on lower weights, but increase the number of repetitions until you feel that your muscles you have to get this burning feeling, you have to have some fatigue in your muscle to achieve an actual improved muscle function.
Dr. Chung, would you like to add anything?
Well, I have a talk about that. I have a Borg scale in my slide, today's talk, which will be available online, I guess. And another way to know when you stop the repetition is that if you can't really do full range of motion, that's another indication that where you have to stop it.
Thank you.
Add something? So I'm not an expert, but I think you see a bodybuilder for about 3 to 5 years. So the affected areas for me are quadriceps, forearms, and a little bit of lower back. So what I do is I have a little bit of a different strategy. The muscles that aren't affected, I've continued to strengthen and train the way that I used to, going to almost failure and everything else. The muscles that are affected, what I'm doing is I'm doing slightly higher reps. I'm leaving a couple reps in the tank. So I'm not going to absolute failure. I find if I go to absolute failure with those muscles that are affected, it takes me a long time to recover, which is a problem, right? So if it's an area that isn't affected, I've trained extremely heavy, lower reps, heavier weight. The muscles that are affected, what I've done is I've gone a little bit less weight, and I've gone to just short of failure so that I can recover. As long as I can recover properly, I feel good about that. And in terms of that, I've been able to keep a lot of muscle on my body, and I think the more muscle you have on your body, the longer you can keep the disease at bay. It's still going to affect you, but you can be able to keep your regular activities going the way that you would want to.
Thank you.
I hope that helps anybody.
Rex Bickers from Indiana, IBM, a member of the board of directors and a kit leader. If it were up to me, the whole MAB would be lab rats. But in many fields of medicine, a neglected area is healthcare research, utilizations, and outcomes. Let's take a chronic disease like diabetes. It's been shown pretty conclusively that a telephone call once a month, maybe twice a month, after hospital discharge, maybe once a week, really improves patient outcomes to just say, how's it going? What's new? And I'm curious if TMA ought to be supporting healthcare outcomes and utilization research. Should myositis patients be getting, maybe it's just once a quarter, a phone call from a skilled nurse practitioner? Or, I don't think it's been studied in diseases like ours, and I'm curious if somebody thinks it's a worthwhile undertaking.
So I really agree with you. I think that we're still struggling with figuring out how to best deliver care. And certainly there are some sentinel moments where it becomes clear that we need to deliver more care. After a patient is hospitalized, even if they recover from what the acute event is, my sense is that we really need to have more hands-on, more touch after that. And so there's, at least as far as I know, I'm a pulmonologist, I'm not a neurologist or a rheumatologist. We've really tried to make sure that every patient who's discharged from the hospital is seen within 2 weeks. And, that's a challenging thing to do, but we found that it sort of helps us make sure people have gotten back on track. And I can imagine that for many patients, having that kind of brief follow-up, if things are not going in the right direction, could prevent them from being readmitted to a hospital. So I think it's a wonderful idea, and I think it just speaks to one of the areas that there's just a desperate need for more understanding.
Thank you. I think we're over here.
Thank you. I want to direct this to the physician or clinician who mentioned a subject that he was looking at medication or developing other medication other than the traditional medication that's being used to treat myositis. And if that's the case, would this prospective medication be more effective, better tolerated? And if so, do you see yourself accomplishing this in the very near future? Maybe I misunderstood the question. Yeah.
Yeah. To whom would you? Okay.
So it's always, as a researcher, I have to be very responsible and not raise hopes if the hopes are not to be placed in something. But obviously, as a scientist, I have to put hope in what I'm doing, or otherwise, why am I doing it? Why am I working so hard to try to do something? So there's a lot of people who try lots of different things, and unfortunately, they don't work. But at this point in time, this is a promising new approach to look at myositis and muscle disorders by trying to find a way to repair the cell membrane so that it prevents that from contributing to further damage. If you ask me in the near future, I would say definitely not the near future. This is something that has to be tested in the laboratory on many levels and then can maybe down the road translate into something useful for patients. So again, it's exciting, but not anytime soon ready for patients. And Raghu said something, he started a quest for something other than prednisone. So you're not off the hook, Raghu.
So I can give a brief update on vamorolone, which is a prednisone replacement. So one of the good things that prednisone does is it works, but it has terrible side effects. So some 10 years back, we started working on how can you separate these two properties, the good properties of prednisone and the bad properties of prednisone. So in order to do that, you have to understand how the bad properties come and how can we block that. So I think a series of experiments done, we reduce significantly the bad properties of prednisone, but we still retain the good properties. As Dr. Jarur mentioned, this is a process. So we started initially in the lab and then move into animal models, then move into patients. And before going to the patients, do trials to see the drug is safe in normal volunteers. So this process now, the drug has been tested in children with the Duchenne's muscular dystrophy. So now we are doing what is called FDA required, something called as a randomized blinded trial. That means the patients don't know what they are taking. So after they complete the trial period, you assess whether the drug is really working or not. So we are almost there, and hopefully the results, we don't know the results yet. So by next year we should know.
How long was that journey, Raju?
So normally, it took us a little more than 11 years, this entire process.
Thank you.
Hi, thank you. I'm listening to everything, and great strides seem to be made in what we're going through. But I want to circle back into one of the questions that was asked earlier. We're fortunate to be able to see some of these brilliant physicians, therapists, on a bi-yearly basis, annual basis. But I think it's very, very important. A lot of us have problems. We see community doctors. You've got communication and collaboration. Fortunately, currently, I sit on one of the national boards of the American College of Healthcare Executives, and we do have communication and collaboration amongst the hospitals and healthcare leaders. I know that frequently we have, as patients, we have charts. Electronic medical records are now across the board. There is a tremendous problem with collaboration and communication with EMR and HIE. Is there any way that we can set up a national registry for myositis patients? Is there a way that we can collaborate through our EMRs, giving authority to our doctors that other hospitals will be able to, if we have an urgent problem, other hospitals will be able to recognize?
So I think the idea of national registry is
It's already out there. Europeans are doing it. We just don't have a very good any national registry in US and Canada. And I'm trying to lead some efforts to develop national registry of myositis patients across US that will involve, 50 to 60 centers in US, which takes care of myositis patients. So I think that's already in work. Obviously, to do any work, you require funding, and that's where we're having some challenges there. But I think this idea is excellent because that's actually going to benefit researchers, patients, and everybody. But I think what you were also talking about is some way of cross-communicating, not just for national registry for research, but more for national registry or sort of a communication between various different EMRs. And I know there's a lot of work in progress in that area where EMRs can talk to each other. So in other words, if you're seeing a community rheumatologist, dermatologist, or a neurologist, and you come and see me, I don't have to get your chart. I can just go in your EMR with your permission and review what has gone through. Or opposite would be true as well. If you go to an ER or a community doctor, they can look up what my thoughts are about you. So I think it's not there yet. We have to do a lot of work to get there, but it's in process.
Dr. Reid?
I know there's two components to that. One was the EMR talking components, and so there are a lot of systems that people have gone on that do talk. And you can see records in many places. The problem is with these two big systems, the two biggest systems in the US, where most people are on, they don't fully communicate, and so that's been hard. And so they have tried to do a lot of national work to allow things like medications. So all the pharmacies are on one communication system, so they can tell when you renew your medications that you renewed it somewhere else before and what the timing is. And so it isn't always a black box. And so more and more people are getting there. We're just not there. I want to comment on the registry. So I am a pediatric rheumatologist, and one thing we have been able to accomplish, not fabulous yet, but I think we've moved forward, is to have a registry around many pediatric autoimmune disease, but juvenile myositis is one, as part of an organization that really was a grassroots organization from the care providers to say, how do we come together? And actually every child that has juvenile myositis, we also deal with lupus and arthritis, but every child that's diagnosed in the US, how do we put their information into a registry format? It's taken a huge amount of work. It's been 20 years in the making, but we actually have it. And the beauty of it right now is if you're able to contribute, not everyone can contribute the information, but if the patients are willing and we're willing, we now can have in a year 1,000 patients with juvenile myositis in this database. So I'll have a question. I can query that database and ask a question. If I can find out how many patients have some unusual side effect, you can query that information and start getting that information back. We've also even tried to go a step further and actually have a large tissue and sample base. So when people want to ask biological questions, they can then apply for samples to be able to answer a question and not have to wait 20 years to build their own data system. So it can be done. It's not easy and it's not cheap.
Thank you. Back here?
Yes, in inclusion body myositis, we know that the inclusion bodies are made up of different kinds of proteins, P62, amyloid, whatever. Do we know, or are there any studies to show if there is a connection between the type of inclusion body and the severity of disease, or maybe a prognosis? And also, I think I forgot the last part of the question now. But anyway, that's the big thing. And we know that MHC1 is upregulated. Do we know why? And do these findings, do the type of inclusion bodies affect the drug, perhaps a drug trial? Does a drug work better in somebody who has P62 versus amyloid?
So I think you're asking absolutely the right question, which is, can we understand from current clinical information, so we're talking about looking on a muscle biopsy, whether a patient has prominent inclusions or aggregates, And whether that predicts somebody to have a different disease, meaning they might progress more rapidly or more slowly, whether that means they might respond to a different type of medication, perhaps a medication that focuses on a certain protein that's accumulating versus a different type of medication. So I think those are absolutely the right questions to ask and answer. And all I can say is we're thinking about those, but I don't know the answer to those yet. And so often I think when I think about those types of questions, I think about how do I take a rare disease and now I'm going to make it more rare because I'm going to put you into 4 different categories. And so in some ways, it's daunting to start thinking about that. As far as the connection between the immune system, so MHC class 1 is an immune molecule that's upregulated on muscle fibers, and the connection between the immune system and why we see protein inclusions in skeletal muscle, that's also a mystery and something that we're actively trying to understand. But you're asking the absolute right questions that we as researchers want to understand.
Yeah, I just want to reiterate what Chris mentioned about MHC class 1. This is what is, for some of you who don't know, it's called major histocompatibility complex class 1. So these are the proteins that almost every nucleated cell in the body makes. The major purpose of that protein is, when viruses or bacteria go inside the cell, they hide. They pick the piece of the hiding bacteria or virus, show it to the immune system outside, that somebody is hiding inside. This is how they look, so that the immune cells can go and kill that cell that is infected. But the problem we have in myositis, we truly don't know any bacteria or any virus inside, because people tried hard to find one, but there's essentially none that is unique to myositis. So what we think it's body's stress response. Any time we are exposed to, so for example, you don't need anything for MSC class 1 to go. Even a crush injury is enough, the class 1 goes up. That is kind of a sensor that some damage is happening and you alert the immune system. In myositis, as the question is again, what causes? We don't know. The answer we don't know. But what is happening, it creates a self-sustaining loop. All the time, the body in the muscle is under stress. It is telling the immune system there is something going on, and the immune system is becoming active. So it's a kind of a self-sustaining loop.
So I just wanted to make a quick comment about that. So I think Chris answered the question about the protein aggregates and the disease behavior. One of the things that we've been trying to study is try to answer the same question, but in relation to the inflammation. So is there a difference in disease behavior, disease severity in response to either the antibody or the different types of lymphocytes, atypical lymphocytes in the blood? So some of the studies that we are doing right now are trying to answer that question. But as Chris said, the relationship between inflammation and the degeneration or the protein accumulation is not really clear. And what we don't know yet is which is the primary phenomenon, whether it's the inflammation that comes first, whether it's the degeneration that comes first. And that remains a big mystery at this point.
Dr. Schmidt?
Sorry, it's already multiple answers to one question, and there are more questions coming up, but still, I don't want to keep quiet. Just 2 more pieces to add from my side. The link between MHC and the protein degeneration is the protein recycling machinery, which is called autophagy. In addition to what Raju said, is the MHC1, there is an MHC class 2. And interestingly, this MHC2 has been shown to be linked to inflammation and the degenerative part of IBM. And now I'm bringing this up because there might be some light at the horizon, because there has been a study with rapamycin, which targets exactly this protein recycling machinery. And there is currently an international effort to mount a subsequent larger trial in IBM, so maybe this would be of interest. And then just in addition to what Dr. Mozaffar just said, in terms of the HENA question, what comes first, inflammation or degeneration, the information in the international literature so far has shown that there is several lines of evidence that inflammation can drive degeneration, whereas there is no information so far available that the reverse might be true as well. There is no information that degeneration can drive inflammation.
Thank you.
Yeah, just very quickly, not to belabor this, but our paper from 2016 shows that link where degeneration can drive inflammation. Thank you.
Yeah, my name's Ron Hendrickson. I'm new to this. And our care team tried to be very helpful, not familiar with this. And a number of things have surfaced that we're curious about. Our primary care specialist, our physical therapist, has said, look at anything that enhances cellular function. And the four things that have come up are hyperbaric oxygen, things like the Myers cocktail, acupuncture, and I'm very curious, and cold laser therapy. I'm very curious, is there any data that any of these things, which are supposed to enhance general cellular function, are either harmful and contraindicated or may be helpful? Everyone agrees there's no cure, and this isn't gonna make that fundamental difference, but it might slow the disease or enhance your current status. And we're very curious if there's any data either for or against any of those things.
Dr. Lloyd, can I ask you to try that one?
Thanks. Okay, thank you for giving me that very challenging question. So the answer I think is in myositis in general, there's not any data that I'm aware of any of these alternative therapies like laser, hyperbaric oxygen, acupuncture, massage, etc. In general, my feeling is sort of like with any supplement, like a antioxidant. If there is any theoretical evidence that is possibly helpful, if the actual risk of harm is extremely low, and the cost is not in any way prohibitive, then I'm certainly in favor of trying sort of experimental alternative therapies. I think there's a lot of evidence out there of the power of actual positive thinking, and a placebo effect is real. So if there's something out there that you're interested in trying, that you've read about, others may have actually told you they think is beneficial, and it's safe, and I'm of the overall opinion, why not try it?
So I just want to add something. So there is one randomized control trial of exercise in IBM. So the group that exercised increased muscle strength a little bit. It wasn't a significant change, but it was definitely a sustained muscle function. To compare with a non-exercising control group that actually declined during these 12 weeks. So I'm pretty convinced that doing regular exercise, being active, helps you to sustain your function with IBM. And I think the only way to become stronger is to actually put mechanical load on your muscles.
Thank you. I'm sorry. In the back?
Hello. I just want to know, as a minority and a person of darker skin, how can we raise awareness and or educate physicians across the border of myositis symptoms in us? Because as we know, we have different antibodies, and I was like misdiagnosed and I had the overlap symptoms, and it was hard to do that. So how can we raise awareness with physicians for minorities and saying, oh, they have myositis? Because on the internet, you don't see any pictures of individual myositis of darker skin. You just see Caucasian or Europeans. And that can be difficult. We need to be raising more awareness for minorities to discover those symptoms.
Well, let me start by saying that TMA spent the month of May, Myositis Awareness Month, trying to do that exact thing. We had a campaign with a wonderful group of advisors from our support groups who helped us to develop an awareness campaign about myositis in women of color and the differences that they experience. We've got a handout on our resource table if anybody's interested in it, and it does have women of color all over it. So, and and those of you who are here can pick one of those up and take it to your doctor and start there.
And I'm sorry, this is Mary McGowan. Just to add to that, it was a really successful national campaign, as Linda said. We'd reached over 5 million people. We had 11 published articles throughout the nation. And so what our plans are is to continue that effort, of course, throughout the year, but with another significant emphasis on this upcoming Myositis Awareness Month. So thank you very much for the question, because as we know, women of color are at highest prevalence for PM and DM, and it's critically important that we raise awareness about this, both at the clinician level and the patient and families levels. And thank you.
Thank you, Mary.
I just wanted to say that, I absolutely agree with you, and I think that the TMA has been amazing in raising this level of awareness. And I think it's like what a lot of people have said is, you have to, because everybody is cared for by a different provider, it's really important for you all to help educate your doctors. I mean, I think in business they call it managing up. It's the idea that, you're bringing back unique information. I love the person who said that they brought the Myositis 101 and they're going to give it with a cookie. I mean, you really also need to help educate both your doctors, your community. I have patients who go to rehab, they educate other patients in rehab. I mean, this really is a community effort. It isn't going to be just the TMA educating people or the doctors who are up here or other doctors educating people. You all are the most powerful spokespeople, and so your ability to go back and say, hey doc, here's what I learned about my disease. I think that doctors want to provide the best care they can. I think it's just there's so many different things that are coming into them. There's nothing more important than what your patient says to you. So please, please, please carry back these messages to your doctors.
I just want to add to it. So one of the ways the doctors get educated is through research, and then that research becomes medical, goes in the medical books. So I would appeal to the people of minority community to really step up for research as well, because most of the research when I read and review is about Caucasian populations. So I think there is a need for us as a researcher to preferentially enroll people with color, and also for people with color to actually participate, volunteer for more research. Because if the research goes in, then you will see those same pictures and same education going in the medical textbooks and go from there.
Thank you. Over here.
Okay. Question about autophagy and
the misfolded proteins and things. I know that some of the intermittent fasting and the, time-restricted eating, 12 to 14 to 16 hours between, your last and your first meal, is supposed to help with autophagy. Has any of this been studied with any myositis, and if that helps the autophagy a little bit? I mean, because we don't really have a cure right now, and, if we can do things with exercise and that to help hold it back a little bit, I think that's the goal for those of us who are looking for something.
So I'm going to give the same answer I've given many times, which is I don't know the answer for sure. However, I think there's good reason that autophagy, which is Latin for self-eating, so it's basically how a cell recycles damaged proteins or damaged organelles within the cell. So it's basically the trash system in the cell. And the hypothesis is that in inclusion body myositis, that there's an accumulation of trash that can't be disposed of. And so the hypothesis, again, would be that if we increased autophagy in skeletal muscle, that might be therapeutic in some way. And that's a reasonable thought. And the ways to do that can be through a lot of different ways. It could be through giving certain drugs. So one example is the drug we heard about earlier, rapamycin, where rapamycin might stimulate autophagy and be beneficial. Another is, as you said, caloric restriction, so intermittent fasting. The issue with caloric restriction and intermittent fasting is I don't want to cause anyone any harm. And so a lot of patients will ask me, well, maybe it's known that if you have a high protein diet, you actually inhibit autophagy. Well, it's also known if you have a high protein diet, you build muscle. So I just can't answer that question at that point, but I can say that we are looking into those questions and trying to understand them. And I think this therapeutic trial with rapamycin, which is being done overseas, and maybe Olivier can comment on the results of it, is very exciting to see if this is to kind of answer the hypothesis, to actually answer that question. So.
Rapamycin in our hand on 22 patients compared to 22 with a placebo after 1 year of treatment shows some stabilization of the disease in terms of 6-minute walking distance, which remain exactly the same for the patients under rapamycin and which decline for those under the placebo. And also we perform some quantitative MRI to quantify the fat replacement of the muscle, and we can observe the same kind of results, stabilizations under rapamycin and an increase of the fat within the muscle in the patients with the placebo. So I think that's the first interesting signal with a molecule for IBM, but we have to reproduce these good results in one other cohort of patients.
Thank you. Over here.
Thanks everybody for being here. My question is related to clinical trials and the role of the 6-minute walking test in clinical trials, and what are the pros and cons of using this test, given the heterogeneity of IBM disease and the affection of probably certain quadricep muscles and other ones, and how you guys see this moving forward as an endpoint, primary endpoint for some of the future clinical studies.
Dr. DeVisser, can you?
Yeah, I think that's an important point, and there has been a large trial that has been published just very recently that failed in IBM with bimagrumab, and that trial used the 6-minute walk test as primary outcome. And I think it is very important to choose an appropriate and the best possible outcome for any trial, including IBM. At the moment, I think it is difficult to provide a final answer to that. My personal opinion would be that there are other outcome measures that could be potentially more appropriate than the 6-minute walk test. And one of them would be, for example, the IBM-FRES, which is a functional composite score of different functions of the hands, feet, and the general well-being and the everyday capability of living. And this has been validated for IBM, and that could be used for future trials in IBM. And but I think that more research would be needed as we go for subsequent trials.
So one of the intentions of the long-term natural history study that we are planning, and it's a 13-site consortium that we have put together, would be to study all of these measures in the long term, over a 48-month period. Because I think the concern is that IBM-FRS, the 6-minute walk test is not sensitive enough. It's been shown by the Nationwide Children's Hospital Group that of all the measures, the 6-minute walk test has the least sensitivity in terms of detecting changes. There are other tests like time get up, which is a measure of your proximal strength, IBM-FRS, you have the stair climb. So I think the problem is all the data we have is 12 months. Whether it's coming from the Bruma-Grumab study, whether it's coming from the phase 2 of the aramoclomol study, we don't have data beyond 12 months. So it's very important to collect this long-term longitudinal data on how they respond, but also try to stratify it. Is all IBM the same disease? Are the IBM differences based on biomarkers, based on maybe, as somebody suggested, protein aggregates? I think there are questions that are still left. So I would answer the question in saying that we don't know what the right measure is right now.
I'd like to add the following. Most of the patients with IBM have severe difficulty with walking, but there are also patients in whom swallowing difficulties are the most important problem, or hand function. And that is not being captured by a 6-minute walk test. So my feeling is that we should include other outcome measures, like, for instance, a swallowing questionnaire or specific tests for hand function.
Thank you. Over here.
Yes, I have probable IBM with PM Cox. I was diagnosed in January of 17, and last October also diagnosed with carcinosarcoma. So I went through surgery and chemotherapy. My neurologist is urging me to do a methotrexate for the IBM, and just curious if there's any caveats. In my case, I'm scared to go back on it.
Chris, do you want to take this one, or do you want me to take this one?
Why don't you take it?
Okay. Since we both come from WashU, and WashU was responsible for this entity of PM Cox. So I think the issue comes up is that there was a syndrome that was described about almost 20 years ago, where the patient had inflammation on the muscle. They had Cox negative fibers on the muscle, but they did not have the rim vacuoles or the inclusion, and this entity of PM Cox was described. I think the feeling, at least in the community, is, and this is corroborated by the fact that a lot of these patients also have the anti-5C1a antibodies, is that this probably is IBM and not a separate syndrome on that. Now, Todd Levine and Alan Pastrong had suggested that methotrexate may stabilize some of those patients, but I think in general the consensus right now is that methotrexate probably doesn't make a difference, and probably should not be recommended at this point.
Thank you.
I was wondering, how important do you think it is to have an MRI before a muscle biopsy? And do you think that just like any general pathologist should be able to read a muscle biopsy, or would you recommend going to like a myositis center for that?
So I'll take this. So I don't think an MRI is required So I think that thoughtful decision-making on what muscle they're going to choose is what's required. And if the physician needs an MRI to make that decision, then maybe that's what they need. But you typically, if the physician is thinking about the patient and makes a decision on what muscle based on perhaps electrodiagnostics, so sticking the EMG needle in, that might help them understand a muscle that's affected. Sometimes an ultrasound can help, but I don't think an MRI is required. I think what's required is a physician that's thinking about, well, I think this would be an appropriate muscle to choose. I do think that just as we go to specialists for certain diseases, there are specialists in certain pathologic features as well. And so a community pathologist who hasn't read a lot of muscle biopsy, there's actually specialists in muscle biopsy pathology, should be the one that looks at the muscle biopsy. In addition, many people don't realize this, but just like you can get a second opinion by seeing a physician, you can actually get a second opinion on your pathology. So often what we'll do is we'll have somebody send their muscle biopsy to us, and we will reread the muscle biopsy. We'll read it just like we would read a normal one and issue a report. And also what we occasionally do is if the studies weren't done in a way that we think they should be done, or if there's extra studies that need to be done, often we will actually ask for the piece of muscle. So another thing people may not realize is that if you had a muscle biopsy, your piece of muscle is often maintained at the same site where you actually had the muscle biopsy done. And so we'll get that piece of muscle sent to us and we will reprocess it. And so I do think that, that it's critically important to have a neuromuscular pathologist review your muscle biopsy.
I tend to disagree with my distinguished colleague with regard to the first point. There are data that show that diagnostic accuracy is improved by doing an MRI prior to the muscle biopsy. So an MRI can guide the surgeon to the area with the inflammation. And in particular, it's very important that in people who have IBM, who are suspected of IBM, and where the muscle of the quadriceps is replaced by fatty tissue, that you are certain that an affected but not too affected piece of the muscle is being targeted at. And with regard to the second part of your question, I totally agree. I really think that people should go to a myositis expert center, also because specific skills are required to process the muscle, let alone reading the muscle biopsy, which requires specific skills.
Dr. Schmidt.
Yeah, I agree, of course, with every word that Dr. De Visser just